Kia ora koutou katoa. Welcome everybody to the first of this year's lunchtime um, seminars and professional seminars. And we're very lucky today to have Sally O'Connor with us. Sally is nurse consultant in clinical governance at Health New Zealand, and she's going to talk today on the fundamentals of care, a journey to achieving excellence in care. And Sally has been working with the fundamentals of a care community, if you like, for a number of years now, or a number of months now, probably. And she is passionate about this, I would say, and has been talking around our organisation to a number of groups. But I'm sure there are some people who haven't heard Sally talk on fundamentals of care. And I think Sally equally organisations outside of ours will have an interest as well, talking about primary care and aged care and so on. So thank you very much, Sally, and welcome everyone.
Thank you. Thanks for the introduction, Lorraine. So, I've been involved in the Fundamentals of Care program probably since this time last year, but it's certainly been something at Southern been looking at for a number of years. And Jane and I first went to Auckland to a Fundamentals of Care conference probably about 5 years ago. So, what I'm going to do today is I'm going to talk you through why we're doing this program, what it's all about, what some New Zealand research has found, and how we're going about it for Southern. So, Jane and I went to the leadership program October 2024. And at that point, we developed a vision for what we wanted for Southern, and that was to create an environment, culture, and change that embraces a person centered approach that improves the experience and quality of care. So that's what we're essentially aiming for. The fundamentals of care framework. It was developed by the International Learning Collaborative. So the International Learning Collaborative has got a website that's got a number of resources on it that are open to anyone to access, but Health New Zealand is also a founding member, so has open access to all the resources on this website. So this framework was developed. The framework here that you can see on the left-hand side was developed by the International Learning Collaborative, which is a group of senior nurses from across the world, essentially. And they were looking at what was essential for care to be effective. There's three dimensions to fundamentals of care. Right at the center of that framework is the relationship, which we all know that if we don't form a relationship with our patient, it's pretty difficult to get beyond that. So that's around, trust, anticipating, knowing, evaluating your patient. Then we've got the integration of care, and within here, there's three dimensions. Two dimensions are what the care recipient needs. So obviously your physical needs and your psychosocial needs. And then this bit here is your relational caregiver action. So this is what the caregiver has to do to be effective and make this whole integration of care work. So being empathetic, helping patients to cope, being present, etc. And then this whole framework sits within a context of care, which we are all working at. We've got the policy context, so your policies, procedures, governance, quality, and safety. And you've got all your system level stuff, resourcing, leadership, culture. And it depends where you work. Aged care, for example, will have different contexts of care issues than Health New Zealand. There'll be much more, I guess, funding, resourcing issues, those sort of things that are really impacting on the way that you might deliver care to older people. Within primary care, it'll be, what's happening in those clinical general practice environments, advanced nursing practice, all of that sort of stuff. So it really depends on where you work. This framework can be utilised across all care areas. And we've certainly been using it in our inpatient wards, theatres, intensive care, children's ward, and all of our community services. Because we practice in New Zealand and have our obligations and core values for kaupapa Māori, there was some work done. There was hui's held in Auckland, where iwi came together and looked at this model, looked at the model on the left-hand side, and talked about how that could be maybe modified or changed, if you like, to incorporate the values that we practice in Aotearoa, New Zealand. But the decision was made that they didn't want to retrofit those values, behaviours, etc., into this model. So there's the model that sits alongside it, which respects the context of care that we're working in New Zealand. So why is this important and why now, I guess, given that we looked at this, 5 years ago? I guess the political environment that we're working in is a bit different at the moment. There's a lot of pressures in terms of targets, recruitment, some of those things that perhaps hadn't been as obvious in previous years. And I guess Jane's concern, Jane Wilson as the chief nurse, that we were actually still keeping the core things that are important to our patient care front and centre, if you like. And some of those headlines that we have seen in our news about staffing freezes and those sort of things. And we know that when the pressure comes on for staffing and recruitment gets affected, that this is the time that patient care can be compromised. And for those of you that have been around for a wee while, you know about the Stafford Hospital scandal and the Francis report. And if you don't know about it, it's worth having a wee look up. But essentially, that healthcare trust was very focused on achieving their financial performance and targets and lost sight of what happened with their patients. And there was patient deaths, poor care, terrible examples of things that happened in that trust hospital. At Southern also, there's been quite a big investment in recent years in nursing leadership development, getting our clinical governance processes and practices in place, and a number of other context of care changes that we considered was probably meant it was the right time to do this versus 5 years ago when we first looked at it. This is a really interesting study that you'll be able to find if you're interested in having a more in-depth look at it. But Fundamentals of Care was first rolled out up in Counties Manukau. And this is the first piece of New Zealand research that's looked at fundamentals of care in practice in a New Zealand hospital. And their aim was to observe nurses and record the nurse-patient interactions against the Fundamentals of Care framework, to get nurses' understanding, to explore what patients was important to patients, and to explore nurses and patients' understanding of culture and spirituality, and identify the barriers and facilitators to delivering integrated care. So what they did was they did some semi-structured interviews, and they also did data collection, observing and recording nurse activities. So they followed nurses around, and they did interviews with both nurses and patients. And 13 nurses were observed, registered nurses, and they managed to interview 7 nurses and 5 patients. How this framework was introduced in counties was as an audit tool to compare how nurses and wards were going against the Fundamentals of Care framework. That's not how we've implemented it at Southern, so I'll tell you more about that later. But obviously the findings demonstrated that nurses saw Fundamentals of Care as an audit tool. That they recognise the importance of physical care with little emphasis on relational and psychosocial aspects of care. Some nurses prioritise reading notes versus conversing with patients, and 3 nurses thought the best way to understand their patient requirements was to read the notes. All nurses understood the elements necessarily to establish and maintain relationships, but struggled to give examples. When they talked to the patients felt they were well cared for. Communication and listening to patient concerns were essential, and patients really appreciated nurses when they could spend time with them, but they were also very aware of ward busyness. And during those times, I guess what we see, express reluctance to ask for help. And patients had a selfless concern for the well-being of others, so they would think that the other patient in the bed across the room was sicker than them and therefore needed more attention than they did. And the patients were very aware of when nurses are not busy and not attentive. So they could recognise busyness in the nurses and unwellness and need in other patients, but they're also aware of when the wards aren't busy and when nurses weren't attentive. So that was quite an interesting finding, I thought. In terms of culture and spirituality, the nurses knew, because I mean, I don't know in the practice settings that you're all from, because I can't see any of you today, but our admission form clearly has a bit of a tick box where we ask about culture and spirituality. And nurses knew that they had to do that on the admission assessment, but the spirituality, when questioned, was associated with religion, and most nurses could not articulate cultural or spiritual needs in any other way, which was fascinating. What they also found was there's obviously barriers in facilitators to delivering care. So technology became both a barrier and a facilitator. So computers on wheels, patients saw that as a nurse, if the nurse was standing behind the computer, not engaging with them, looking at the screen, etc., as a barrier. But also it could be an enabler and a time saver. Board context was important. Inefficient handovers, those sort of things were difficult sometimes. Other enablers were things like having safe, decluttered work environment, having time available. Family involvement could be seen as both a barrier and a facilitator, and also vital, obviously, in helping with a plan of care. And student nurses were both viewed as enablers and barriers, depending on how that relationship was and how far through their training they were. So it was an interesting look. And one of the observations, so it's worth a read because there's quite a lot of narrative in that piece of research. But in one situation, a nurse was doing a dressing on a patient and was observed for, I think it was 45 minutes. The only communication with that patient during that observation period was when the nurse was doing the dressing and it caused a bit of discomfort for the patient. And the patient said, ouch, and the nurse said, sorry. And that was it in terms of communication. So it was a snapshot basically just on AM weekdays. It was a single site study. All the participants were female, and no Indigenous Maori. And then New Zealand went into lockdown. And so there was a bit of a pause, and some of the ability to observe family and caregiver involvement was limited because of that. So it will be great to see some more research done into fundamentals of care in New Zealand hospitals. There's certainly quite a lot of literature available from international studies. So just as a reflection on that, because I thought it was fascinating that this study found that there was an emphasis on physical care, but less emphasis on some of that relational care. We had a clinical coach workshop here at in Dunedin yesterday, where we had about 30 clinical coaches attend the workshop. And as part of the workshop, we did a session on fundamentals of care. And I asked each of those clinical coaches to write down from their clinical area one thing they thrived at and one thing they'd like to strive for. So this was across multiple clinical areas, from children's ward through to intensive care, adult wards, neonatal, etc. What came through exceptionally strongly, so this wasn't about their individual practice. They had to do their individual practice separately. This was about how they saw their ward. And what came out was they thought that they thrived at compassion, empathy, and trust, supporting families, and communication. The things they thought they could do better in were physical care needs, rest, sleep, mobility, hygiene, and privacy and dignity. So almost an opposite from what was observed in the study. This is not scientific at all, but this was just their perception, and I thought it was incredibly interesting. So, what are we doing at Southern? How are we implementing fundamentals of care? Well, we formed a steering group, so we've got representation across all professional groups, really, allied health, medicine, nursing. We've got input from our cultural teams, etc., which is helping to keep us on track, our directors in nursing, etc., on that group as well. We started off with the leaders, our charge nurse managers, associate charge nurse managers, all those people that are in leadership positions. And because we've been running the LEO leadership, Leading Empowered Organisation program for about 3 years, I think, we've had a huge cohort of our nurse leaders through that and thought they were ideally positioned to help lead and support this work. So you don't have to be a LEO graduate to attend, but it certainly helps. And we've run engagement workshops with lots of videos, stories, and tried to link it very closely to what's happening in our clinical areas. There's a Flinders Care Assessment tool, which is available on the International Learning Collaborative website, where you can do a self-assessment. I think this might be member-only access. You can do a self-assessment to see how you think you can score yourself against the fundamentals of care framework. So all of our ward areas, units, etc., have done that. And there's also a leadership assessment tool, which we haven't used. And then we've conducted face-to-face patient interviews. So for every group going through every ward, I've done interviews of a cohort of patients on their ward against the fundamentals of care framework, asking some key questions about care. And then we've looked at the adverse events, complaints, etc., against that framework. And then the wards look at all that information. So they come along to 2 half days. The first day is focused on, what is fundamentals of care? Why are we doing it? How do we lead it? And then the second day is focused on looking at their ward or unit data and how they want to tackle fundamentals of care in their area. And then a 3-month check-in to see how they're going and what they've achieved. We're also trying to embed the fundamentals of care into everything that we do. So this is not a project that we're going to tick the box in 6 months' time and think it's done and dusted. We're incorporating it into all of our policies, orientations, so the practice development units, including it, and their onboarding processes, etc. We've got it included in our quality and safety walkabouts, our clinical governance framework, all that sort of thing. So how are we getting on? We've run 9 workshops. We've had 170 people through. And then we had the clinical coach workshop yesterday where we had another 30 odd people through. So we're up to well over 200 people. Now it's 40 departments or wards. We've had really positive feedback. So people enjoy the 2 days. They like it being broken up into 2 half days. And we've had a range of practice changes. And the feedback loop and expectations in terms of the monthly reporting for the charge nurse managers is included in their reporting on fundamentals of care. This is just some of the feedback that we've had from the day, and I think having Jane always presents at the workshops on why we're doing this and why it's important, and I think that's really set the tone and has provided the leadership from our chief nurse about, why this is really important to her and important to Southern. People really enjoy the connection. They like the focus on patient care and actually talking about that. So often we have sessions or workshops and we're not really talking about building relationships and trust and things like that with our patients. And we've tried really hard to keep the program quite generic so it appeals to different services. Obviously, there's videos and things that we can change and we can put a different slant on it depending on that group that we're working with. This is just to demonstrate how we're incorporating it into everything that we do. So we have a ward process care delivery manual at Southern, which basically outlines the expectations for how we want wards to run and the practices that should be in place. And then what we've done is we've just linked all of those things, if you like, to the 3 key dimensions of fundamentals of care. So if we let's just choose one, bedside safety check. So that builds trust through consistent safety practices. So the patients see you coming in, checking the bedside equipment, and hopefully that will make them feel safe. And you're hopefully having a bit of a chat with your patient at the same time. It integrates the safety with patient comfort and dignity, and it's performed in the patient's immediate environment. And we have process support for that. So we have, things that you have to check off, etc., to state that you've done that. So that's just how we're trying to make the link with every sort of everyday thing that we do. So it becomes common language, if you like. Different areas have done lots of different things. So the 4th floor, for example, wanted to explore with their clinical team as part of their work after coming to the workshop what nurses actually thought about fundamentals of care. So they made up some short questions to get some feedback from that, and they're still working through the next steps based on that feedback. This is Southland Children's Ward. So they wanted to improve their My Care Plan boards. So there's a board at the head of, or somewhere in a good location near your patient in the ward. And they felt that their board wasn't very child friendly. There were things on it that didn't help that integration or communication with children and families. So they set up a group. They've worked through, they talk to families, they talk to staff, they talk to children, and they designed a new My Care Plan board, which really features the what matters to you components. And we're trying to encourage that also with the adult My Care Plan board, so those conversations are happening and we understand what matters to the patient. 8 Med has done a huge amount of work, and Alex, the charge nurse up there, does a really great presentation on all of the work that he's done, and I just can't do it justice, but a bit of a snippet really. They've had quite a comprehensive approach, and they haven't just picked off one thing to focus on. They've really looked at the fundamentals of care framework in its totality and have tried to ensure that these things are happening. So connecting with their patients, so their bedside boards, talking to the patients with their name, not referring to patients as bed numbers, introductions, respectful presence at the bedside, those sort of things. Alex also had a clear expectation that every nurse knew their patient by 10 o'clock in the morning and could present their patient at the huddle. So their primary diagnosis, which often a nurse will know that quite well, but what matters to the patient most today is you're only going to know that if you've actually talked to them and you've made that connection. And supporting personal hygiene, because there was some issues with patients in hygiene care. So they actually just ended up auditing patient care, showers, washes, that sort of thing. And every day they focus on things. So they're looking at their pressure injury prevention screening, falls prevention screening, IPC, etc., and really honing in on what we might call, or has been called, basic care. But if you listen to Alison Kitson's video on the fundamentals on the International Learning Collaborative website, she says that this care is anything but basic, and it requires skilled nursing to actually understand the integration of all of these factors of care to be able to do it effectively. The other thing we developed is a quality and safety walkabout guide for fundamentals of care. So each month we have a quality and safety walkabout theme, and the theme for March is fundamentals of care. And so this is a thing, the ward people who work within Health New Zealand will know what this is about, but the charge nurse collects up a group of nurses on the day of the walkabout. They come together around the huddle board and discuss things that are being worked on, and then you can go and talk to the patient as well. So there's some triggers there and some questions that might be looked at as part of this quality and safety walkabout, things for the charge nurse to focus on. So what are our next steps for 2026? Well, the Clinical Coach Day we held in Dunedin yesterday was amazing, and we were so lucky to have a nurse who's just finished her dissertation, it's just been marked, talk about the clinical coach role. So that was a fantastic way to start the day. So we're going to run another day in Southland. We've got some catch-up days for our associate charge nurses and leaders. We've got a few areas to catch up in Southland. Then we're going to move this into mental health. We're holding a celebration day mid-year where hopefully people will come together and share the work that they've been doing and celebrate their successes in relation to fundamental care. We also had Wendy English come down for the Clinical Coach Day yesterday. Some of you might have listened to Wendy English's webinar just before Christmas, where she talked about communication and rapport building. And she ran an amazing workshop yesterday on connection and how to build rapport with patients, very practically focused. And it was fantastic. She had a couple of scenarios where she wrote down communication between a patient and a nurse in a sort of untherapeutic way, and then she did it again in a more therapeutic way and got everyone to test it. And it only took 30 seconds longer to have communication that was meaningful for the patient, because often we hear people say we haven't got time for this or we're too busy, but actually 30 seconds was all it took to make the communication in that scenario more effective for the patient. And then, as I've already said, we're just continuing to link fundamentals of care to everything that we do. Right, that's the end of me talking. So I'm really happy to answer any questions.
Thanks so much, Sally. If anyone has any questions, just pop them in the chat or question and answer section. That was great, and it's so good that you're spreading word, so to speak. It's certainly getting out there.
Oh,
And
Lorraine, I can't hear you. Sorry, am I? Is it just me? You were just a wee bit quiet, that's all.
yeah, hang on. Is that better? Hi, Sally.
No, I can now. You're quite quiet, but that's fine.
Sorry. There is actually a question there in the Q&A, and they said they can't hear me either. Thank you. Thank you, whoever that is. But
Okay.
hopefully you can now talk loudly. Sorry about that. I think it's great that it's kind of you're spreading the word, and it certainly links up with Leo, and also I think it's a framework of care, which I find really useful. And I was interested in you saying that the research, the paper emphasised that the paper that you mentioned emphasised that physical care took primacy over other forms of care, so relational and spiritual and mental. And I think there's always been a problem in healthcare in that we silo those kind of things. You know, like this person needs needs me to talk to him, but somebody else doesn't, or whatever. Instead of sort of seeing them all as a holistically for the one patient. Somebody else has a question for you, Sally. Can you see it about clinical coaches? Will
Oh,
they
yes.
discriminate?
Yeah. So this came up yesterday, actually, at the workshop. And I guess there's quite a lot of challenges around clinical coach roles, and they certainly offer a huge benefit to the organisation. But that's something that the directors of nursing and Jane need to work through around whether they're, permanent. I know a number of them are on fixed terms at the moment. Yeah, but certainly that's a discussion for the directors of nursing to have.
Yeah. Yeah, they've found all sorts of inventive ways to keep them and value them at the moment, but that's yeah, that just depends. Does anybody else have any further questions for Sally? If not, we could maybe finish it there, Sally. And the link, the session has been recorded. The link will be circulated by Trish, and probably over the next few days. And everybody will have. Actually, there is another question. Can you see that, Sally?
Oh, yeah, there is a perception amongst nurses that I'm too busy. How do we overcome this? And I think that was what was really interesting yesterday with Wendy. And we often show a lot of videos in the workshops, and people report that if they just spend a little bit of time connecting with their patient, um, to understand what the patient needs for the shift, etc. And as Wendy demonstrated yesterday, it really only took an additional 30 seconds to do that, they can set themselves up for their shift to be actually better, because the patient understands what the plan for the day is, how it's going to, you know, look. And the nurse understands what's important to the patient. I guess all of these cares are things that we expect to happen for our patients, our physical hygiene cares, mobility, some of the integration of care. And I guess what reassured me yesterday a lot from the clinical coach day was their feedback that they thought that the connection with the patients was really good. They thought that there was compassionate care. Um, they were concerned about perhaps patients don't always get their physical care needs met. And I guess at those times, I think we've just got to all work together as a team and see how we can sort that out. There's certainly a lot of pressure out there with recruitment and staffing, and that does add to it. That's why we do talk about the context of care, being involved in your local data councils and advocating is key. And I know Jane advocates really strongly for trying to make sure that we do have the appropriate resources to deliver the care. She's very committed to that.
Thanks, Sally. There's yet another question, if you can see that they're about students from Rachel.
Oh, yeah. Yeah, I think that's a great question, Rachel. And we haven't, Jane and I talked briefly before Christmas about how we perhaps talk to the Polytech about fundamentals of care and how it could be incorporated into the undergraduate program so that when they come along here, they've heard about it. Um, certainly there's different work streams under the International Learning Collaborative, and there is an education work stream where essentially schools of nursing and uh, academic institutes are thinking about how they're incorporating fundamentals of care into their undergraduate programs. So I'd be really happy to have a wee chat to you at some stage, perhaps offline about that, Rachel.
That sounds good. Anyone else? Anything for Sally? Well, we had a good number of people joining today, Sally, so there's a lot of interest in this, and I hope that the framework will be able to stay in place, regardless of any changes in the health system and so on. Yeah, and I think it's being embedded, well embedded now, and linking up with other things that people are already doing, like the safety walkabouts and the ward processes, and it's not sort of reinventing the wheel, but enhancing and giving a framework to a lot of the care practices that take place already. Yeah,
Yeah, and I think if there's external organisations on the call and they want a bit more information or any links to any of the work that we're doing, super happy to share them. So just email me and I can share anything that we've got that could be useful for you to have a wee look at. There's some great tools that you can use that could be helpful.
that's great. Thanks for that, Sally. I think there certainly were people on the call who are from outside HNZ, so you may well receive some calls. Thank you again. That's a lovely way to set up and start off with the year for lunchtime seminars. Thank you very
Thanks,
much. Thank
Lorraine.
you, everybody, for attending. Okay, bye.